Welcome to Almost Here, Round the Corner Future Technology podcasts with Richard Jacobs. Future technologies poised to transform our lives for better or worse are the focus of this podcast. Almost here means these technologies are now here and starting to be used, or just around the corner, from Bitcoin to artificial intelligence, 3D printing, blockchain, virtual reality, and more.
Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Dr. Robert Rosenberg. We're going to be talking about sleep apnea, Cpaps, and a device that's called the SoClean. It's a medical device which is a hands-free way to sterilize Cpaps to prevent infection. So, Dr. Rosenberg, thank you for coming.
Thank you, Richard. I appreciate it.
So if you don't mind, if we can talk first about apnea and the problems that Cpaps would help, just as a primer for listeners. So, can you define apnea and CPAP, and how do they work together to help a person sleep better?
Sure. Sleep apnea, basically, the most common form is obstructive sleep apnea. In that form, your airway basically collapses on yourself during sleep. So when we go to sleep at night, we lose voluntary control over our muscles and our muscles of our throat. And in people with sleep apnea who are predisposed to collapse, either due to obesity, large tongues, there's any number of reasons, heredity. We have about 18 to 20 million people with sleep apnea, of whom only about 20% have been diagnosed. There's still about 80% out there who have not. And when you have sleep apnea and your airway collapses, your oxygen drops, your carbon dioxide levels go up, and your fight or flight system, your sympathetic nervous system, is triggered. This constricts the blood vessels, increases blood pressure, and puts tremendous stress on the heart and on the brain and then even on the vessels to the kidneys. So this sets people up eventually for high blood pressure, for diabetes, and for a very high risk of heart attack and stroke because of the sleep apnea and because you're not getting any rest at night. Your body is constantly being stressed, whereas normally your blood pressure is 15 to 20 points lower when you sleep at night. With sleep apnea, it's just the opposite. And so Cpap machines are basically machines that generate compressed air. They splint the airway open. You come into a laboratory, and we, with technicians in my lab, for instance, monitoring you all night long, we find the pressure that keeps your throat open while you're sleeping. And once we've devised that pressure and found what the pressure is, that's how we set your Cpap machine. And as long as you wear that machine all night while you're sleeping, your airway will not close down on you, and your oxygen levels should stay normal. And most people start to notice an improvement in fatigue and sleepiness, in their ability to concentrate. Some people notice they're far less depressed when they treat the sleep apnea. So these are all things that go into treatment and the diagnosis of sleep disordered breathing.
My dad had sleep apnea when I was younger. I don't know what it was, but he would stop breathing and he would go, and all of a sudden start breathing, but he would pause for X number of seconds.
Right.
So I know what it sounds like. It's scary. You wonder if the person's going to die in their sleep. It's pretty crazy,
And many of them do.
Really, actually, how often does sleep apnea lead to death?
Oh, frequently. People with sleep apnea, most people who have heart attacks tend to have the heart attacks during the day after they awaken at about anywhere between 10 and 2 o'clock in the 10 in the morning and 2 in the afternoon or 4 in the afternoon. People with sleep apnea tend to have the heart attacks during the night. And unfortunately, in some cases, not all the time, but in some cases, this can also lead to ventricular or cardiac arrhythmias and sudden cardiac death. So certainly, deaths have been implicated that occurred at night in people with sleep apnea who were not being treated. So it's not common, but it's certainly not uncommon, and it is one of the risks of untreated sleep apnea.
Is snoring a precursor or an indicator that apnea is coming or is there?
Snoring occurs in about 40 to 50% of men, maybe 20% of women. So, and certainly sleep apnea is not that common. But snoring is a symptom, especially if it's loud and it's habitual every night, that you might have sleep apnea. Certainly, you can have sleep apnea, and people may not notice you snore, or you may be living alone and no one knows if you snore and you don't know. But usually, the overwhelming majority of patients who do have sleep apnea do have loud snoring, and it's a precursor. It's another stage. Snoring in and of itself probably doesn't cause any issues, but once the airway closes down, and you go beyond snoring to obstruction, that's when you start to have the problems.
Does snoring have the same causes as apnea, or are they different?
No, snoring, you would have the sound of the snoring, but you wouldn't have the pauses. The pauses in the apnea are basically because the airway totally closes, and when you don't hear anything, usually what's happening is if you had the ability to observe them more closely, you'd notice that their chest and abdomen are moving up and down against a closed airway. So you don't hear anything for prolonged periods of time, but that's when they're struggling to breathe, and then that gasp you hear is when their oxygen levels have dropped so low and the stress of not breathing is so severe that they partially awaken and take a breath, and then they go and do it all over again.
Yeah, I know what that sounds like, and it's horrible.
That's what it is. Yeah, my patients, I'll demonstrate it for them, and he'll go, yeah, that's how he sounds, or that's how she sounds.
I know that people have to come into a lab for a sleep study, but it seems kind of counterintuitive. If you want to observe someone and how they sleep, you ask them to come into a lab where they don't normally sleep, and you hook them up to sensors, and maybe they go to sleep at a different time than they normally sleep, a different bed. Is there any way to evaluate this at home, and why can't we do that? Why can't we put like a sensor on someone at home and record their sounds and just figure it out there instead of them coming into a sleep center?
Sure. Well, the sounds alone won't do it, and we do home sleep testing. My facility does a lot of home sleep testing as well as in-lab testing. So the home sleep testing basically it's more than a sensor, but it doesn't require measuring brain waves, so there's no electroencephalograph associated with it. But it monitors oxygen, it monitors pulse, it monitors airflow from the nose and mouth, and it monitors movement of the chest and abdomen with very light bands that are all fed in to the hard drive. And so that's a home sleep test. That's about, you can get coverage from insurance companies for Cpap or for treatment with a home sleep test. Anything less than that, like just wearing an oxygen meter on your finger or having someone observe you snore and stop breathing, that won't cut it. So, yeah, home sleep tests are very useful. I use them frequently. They're contraindicated in some very complicated patients who have heart disease or strokes, and there's some other reasons for not using home sleep testing, but we do use it a lot in people who we suspect have obvious sleep apnea.
And there's no way to solve apnea by just sleeping on your side or sleeping on an elevated pillow or anything, right?
Yeah, no, there's something called position-isolated sleep apnea, wherein the person has almost no apneas when lying in any other position other than the back. Now, we do see that, but it's not common. I'd say I see that maybe 5% of the time, and in those patients, we may recommend a trial of position therapy, where they can sew a tennis ball into the back pocket of a shirt, or they can buy some devices on the market that are sold that will prevent you from sleeping on your back. And so in some cases, we actually do treat the positional therapy, but it's not that common. Most people with sleep apnea, we find in the laboratory that they snore and they stop breathing on the left side, on the right side, on their stomach, and on their back.
Huh. Okay. Interesting. So the Cpap itself, it seems like a really invasive type thing. I mean, I've seen people sleep with them. The air is, being pushed into your mouth. I would think you might feel like you're choking or your mouth would dry out. Like, what are some of the difficulties people have in adjusting to Cpaps?
Sure. The new Cpaps are really, first of all, they're very quiet, number one. And number two, the masks there are all types of masks now. Little masks that go in the nose like an oxygen cannula. Some go over the nose and the mouth. So we usually can find something that patients are comfortable with. The pressures have been changed. There's machines that are auto-titratable, so you're not on a fixed pressure all night. The machine goes up and down according to your requirements. It monitors the status of your throat and your flow. We have ramp features where you can, when you first fall asleep, if you don't want to be exposed to the pressure, you hit a ramp button and it delays the onset of the pressure, and the pressure builds up very slowly over a period of anywhere from 15 to 45 minutes. And as far as the dryness, we now have heated humidification systems and heated tubing, which basically provide moisture throughout the night into the air, so it's comfortable, and you don't experience what people were experiencing 15, 20 years ago, the dry mouth, the dry nose, the nosebleed. So I'm not saying that everybody accommodates the Cpap, because in my facility, we work diligently with people to get them on it and to get them acclimated. But in the majority, we find we have a very high success rate, and a lot of that is due to changes in the technology that people need to know about.
Okay. Can you modulate how fast someone breathes and how deep someone breathes using a CPAP, and is there any benefit to doing so?
Well, the patients on CPAP will breathe at their normal respiratory rate. Okay, it's not driven by the CPAP. All the CPAP does is it maintains a constant pressure in the airway to keep your airway open. But the depth of breath or the rate of breath will be pretty much what it would be anyway, and that's pretty much determined by levels of carbon dioxide and levels of oxygen in the brainstem. And so that's really what determines it. There are Bipap machines that actually breathe for you when you, in addition to the CPAP, maintaining a pressure in the airway, when the person goes to take a breath while sleeping, the machine helps to inflate the lungs, and it actually makes the work of breathing at night much easier. But the depth and rate of breathing is pretty much determined by your own metabolic system and your brain.
Well, there's no point in gently forcing it, or I don't want to call it upregulating it, but making it faster or slower or deeper.
Not unless the patient suffers from some form of diaphragmatic paralysis, and we have to, or they have very, very long periods where they don't breathe at all. Then we will put in a time mechanism. Some of the machines will come in and breathe for you if 4 or 5 seconds has gone by and it doesn't sense any breathing. So there are machines that do that, but that's the rare patient with severe neuromuscular diseases as opposed to the average patient who does not need that with just plain sleep apnea.
And with CPAPs, can you only sleep on your back, or do they have new ones where you can sleep on your side?
Oh, you can sleep any way you want. The mask swivels.
Cool.
Patients sleep on their side. They sleep on their back. I mean, you could probably sleep hanging from your feet if you wanted to. But the bottom line is, no, you're not restricted. That's an old bugaboo. People are not restricted to sleeping on the back when they wear the CPAP. If you like sleeping on your left side or your right side, there's no reason why you can't.
Very cool. So tell me about the SoClean. What is that, and how does it help?
Yeah. The SoClean is a really neat product that's been out for about 7 or 8 years. It generates activated oxygen, which is really ozone, and so it's 99.9% effective in killing bacteria and germs. And the reason that it's important with CPAP is that it's a very effective and easy way to clean the machine and the hoses and the mask. So a lot of people get a little bit lazy. They'll leave the water in the humidifier for a couple of days. They don't clean the hoses. They have to go into the sink and disassemble everything and go through all of that. It becomes tedious to some people. But with the SoClean, you don't have to do that. There's no disassembling it. The mask and the hose goes right into the machine itself. The machine generates the ozone or activated oxygen, which goes through the machine, the humidifier, through the Cpap machine, through the tubing, through the hoses, and basically kills off, like I said, over 99% of all bacteria and germs that are formed. So the advantage of the SoClean is, number one, the convenience is phenomenal. You just put it in and take it out 2 to 3 hours later, and you're done. And the effect on infections, we see in my practice, for instance, people who use SoClean frequently went to it because they were getting frequent respiratory infections, and then we see that they don't have the respiratory infections they had before, that the amount of time spent dealing with infections decreases, and I think it's more than coincidental. I think it's the fact that they're cleaning their machine regularly and that they're using a process which is so effective as opposed to just using soap and water.
Is the ozone running through the system on a clean cycle? Not when you're using the CPAP, right?
Oh no, never. Yeah, the ozone is long gone. It's returned to its native state of oxygen. That's why the cleaning cycle only takes 5 to 10 minutes, but then there's a 2-hour period during which you're not to use the mask or open the machine. You let it stay, and after 2 hours, there's no residual ozone whatsoever. But certainly you don't breathe in the ozone, and the ozone is never being generated while you're on the machine at night. That has been dissipated hours before you put your mask on again and turn your machine on.
So it's a good protocol to wake up, and as soon as you wake up, put on the cleaner so it's ready for the night?
Yeah, you can do that. Most people just when they get up in the morning, they go to the SoClean, they put their mask and hose in there, they attach the SoClean to their machine, and the ozone generates, and that's it. You can even set it on a timer. There is timers that come with the machine. Some people set it for 11 o'clock in the morning, and it runs until 1 in the afternoon or whatever. But yeah, that's the way to do it. And most people, when they first get up in the morning, that's when they put their mask and hose into the SoClean and turn it on and let it do its thing.
What about putting this on humidifiers?
Well, it cleans out the humidifier, because the ozone goes right through the machine and into the humidification chamber. So that's the beauty, actually, of the SoClean, because the major source of infection, we believe in many cases, is the humidifier, the standing water, or even drops of water you can't appreciate even after you've cleaned it with soap and water. But with the ozone, it totally just sterilizes it. So yeah, it goes right through the humidifier as well as the mask and the hoses that connect. So if you go on www.soclean.com, there are several films that demonstrate how it works. It's very easy to do it, and it's very effective.
Well, I just, humidifiers is, I'm just thinking here, it's another market. I don't know how expensive the SoClean is, but if you could have a SoClean device that could work with a lot of humidifiers, it would just be another market for the device, and people that have humidifiers need the help too.
I see. Yeah. I mean, if you're talking about that, then you obviously, that would be something that the people in research and development at SoClean might be familiar with. I'm familiar with with its ability to sterilize the humidification chamber in the Cpap, and almost all Cpaps now come with heated humidification, and that's the nice thing about the SoClean is it sterilizes it.
Okay. So what do you find are the misconceptions that potential patients have out there about apnea and about Cpaps? Have we covered them all, or are there other ones that we want to bring up?
Yeah, no, I think there's some of the misconceptions are that the machines look like they did 15 years ago. Okay, that they're big, they're bulky, they're noisy. What they may have seen their uncle or their cousin or their father on. And the machines are not like that anymore. So that's the first thing. The second thing is some people think that they can wear it just a couple of days or 3 or 4 days a week, and that's not the case. You need to wear it every night to get the benefit to prevent the cardiovascular and cerebrovascular complications of it. And then with the SoClean machine, it's so easy to clean nowadays. It's not, it's easy to do so. So the care of these machines and making sure they're sterile and clean has become far simpler. But there's a lot of misconceptions about sleep apnea. Also, people think that everybody who has sleep apnea must be obese. Well, no, about 30% of my patients and 30% of people with sleep apnea are not obese. They're thin. So, and it's not just a disease of the obese. It occurs in women after the menopause. They quickly catch up to men when they lose the protection of estrogen and progesterone. And so it's a common disease. As a matter of fact, one recent study came out and showed that if you take people from the age of 30 to 70, an average of 1 out of 4 has sleep apnea.
Oh, wow. That's crazy.
That's a lot.
Is there anything people can do to strengthen their throat? I don't know.
That's a good. There was a couple of studies about people who learned to play the didgeridoo, which is an Australian machine. They seem to. That was one, and then there has been some studies with people with very mild sleep apnea that going to a speech therapist and doing exercises for the tongue and the throat and strengthening the tongue and the throat may be beneficial in some people. So I have some people with sleep apnea and very mild and let's say they just can't tolerate the Cpap or they refuse to wear it and they want another option. So occasionally I'll send one to a speech therapist. We'll retest them later on, see if it's really helped. In some cases it has. So yeah, there is something to, and also exercise. We find that people with sleep disordered breathing who exercise seem to, the amount of times they stop breathing an hour drops when they exercise regularly, irregardless of whether they lost weight or not. So for some reason, there seems to be a relationship.
Well, if someone's on a Cpap machine and they start exercising, and let's say they start doing, lessons or strengthening of, their throat and everything, I don't know if they can get off the machine, but would the machine just work better for them if they're less
if their muscle is toned better, if they're in better shape?
Yes, it probably would require less pressure. So the machine wouldn't have to generate pressure that's as high. It's similar to when people lose weight. When we have patients who lose significant weight, the first thing we notice is that sometimes the pressure on the machine becomes too much for them because it needs to be lowered. And the second thing we notice is that with significant weight loss, if we retest them, sometimes they no longer have the sleep apnea. For instance, if you take bariatric surgery, and the majority of patients undergoing bariatric surgery have sleep apnea. As a matter of fact, there isn't a bariatric surgery center in the country that doesn't insist on you getting a sleep test before they'll operate on you. After patients hit their target weight, we find about 50 to 55% no longer have sleep apnea.
That's okay. That's great.
So there are natural cures. We try to encourage obese patients to lose weight, and one of the things methods we do to encourage them, and which is a truthful method, is we say, if you really lose a lot of weight and we retest you, you may not longer have sleep apnea.
Yeah, when you were talking about using it every night, I've just heard anecdotally a few stories of people that had a CPAP and didn't use it for some reason, and then they died. So it sounds like it is critically important once you use it to keep using it.
Yeah, once you use it and you get the benefit of it, the benefit isn't going to last if you stop using it. You're going to go right back to where you were. Your blood sugar is going to get high at night. Your blood pressure is going to go back to skyrocketing at night, and the stress on the cardiovascular and cerebrovascular system will return immediately. So what people need to understand is the CPAP is not a cure. It's a treatment. It's like a blood pressure medication. If you stop taking your blood pressure medication, there's a good chance your blood pressure is going to start to go up again. Same thing with the CPAP. If you stop using the CPAP, there's a very high probability that your sleep apnea will return to exactly where it was before within the first night.
That's amazing. So what any other interesting developments, or what's new, what's coming for the world of apnea and sleep apps? Anything interesting or different?
Well, we do have what we call the hypoglossal nerve stimulator, which has been developed, and it's not easy to get approved for it. But some people who can't tolerate CPAP, or who have severe sleep apnea and require treatment to prevent heart attack and stroke, there is a device that's implanted into the chest wall, and it monitors your breathing, and it also sends current to the hypoglossal nerve, which is the muscle that controls the nerve that controls the muscles of the tongue. And basically, when it senses you're breathing in, when you sleep at night, it gives a little electrical shock to the hypoglossal nerve. The tongue protrudes, and it prevents the apnea. So that's something new in sleep disordered breathing. The other one is the oral appliances. When they work, they're very effective, and I have a lot of patients who utilize oral appliances. When they work, they're great. Unfortunately, they don't always work. The beauty of the CPAP is it's 100% foolproof. If you wear your CPAP, your airway is not going to collapse at night.
What is an oral appliance?
An oral appliance is made by a dentist, usually trained in that they take a mold of the upper and lower teeth. The appliances are adjustable, and you only wear them at night, and it brings the jaw forward. And by bringing the jaw forward, it brings the tongue forward, and in many cases, that's enough to prevent your airway from collapsing. So you put it on at night, and it brings your lower jaw forward, and then you take it off in the morning, and then you put it on every night. And for some people, that will prevent the sleep apnea. And a lot of people like it because it's non-intrusive, it's non-invasive, it's easy to use, and it's comfortable.
Well, I think I've seen that, like the Snore RX. It's like a mouth guard that you bite that molds to your mouth. And
yeah,
I've seen one or two things like that.
Those don't work for sleep apnea, unfortunately. The ones you get at the boil and bite stuff most of the time doesn't work. I'm not saying it never works. The ones made by a dentist who's trained, usually a member of the American Academy of Dental Sleep Medicine, these are much more sophisticated. They're not boil and bite, and the dentist literally adjusts it incrementally for you to prevent the apneas, and usually sends the patient to a place like mine where after the device has been brought forward to where the dentist thinks it's effective, we then test the patient to verify that it's working. And a lot of times it does work, so when it works, it's great.
Okay, gotcha. And then I forgot to ask you, what is considered severe apnea? What is considered non-severe? What are some of the parameters that would show up differently in someone?
Okay, good question. Yeah, textbook-wise, it's determined by the number of times you stop breathing an hour. So 5 to 14 is considered mild, 15 to 29 is considered moderate, and 30 or greater is considered severe. But most of the studies have shown when you stop breathing over 20 times an hour, that there's a rather higher risk of heart disease and stroke in those patients. So those are the ones who are at greatest risks and really should be treated. That's not to say that even people with mild sleep apnea don't develop heart disease and other things as a result. But statistically, on the studies, it's at about 20 or so, we see a real significant increase in the incidence of heart attack and stroke.
Okay. Yeah, I didn't want to say it to scare people, but I also wanted people to appreciate, how bad apnea can be.
Oh yeah,
and,
it's very important people understand that it's a silent killer. You're really not aware of it because you're sleeping when this is going on, and you're not aware of what your body is going through, unbeknownst to you, because you're not breathing.
And the only indicator you may or may not have is you wake up tired or foggy or exhausted,
or your bed partner, if you have a bed partner, or your bed partner. But otherwise, yes, you wake up tired, exhausted, have to have 3 or 4 cups of coffee to get going in the morning, find yourself dozing off in the afternoon, sometimes at work, sometimes at school, sometimes, you start to notice there's a difference, may start to notice that your memory's not as sharp as it used to be. You start to think, oh, I'm 55, I'm 60, it's my age. No, it's not the age, it's lack of oxygen to the brain at night. That gets easily reversible when we treat the sleep apnea. That causes some people actually get diagnosed as early dementia, and we find out they have sleep apnea and they don't have dementia.
Wow. How long do people, I don't know if you know, but how long do people typically have sleep apnea problems before they see you?
Oh, I would say it's getting better, but it's frequently 3 to 5 years before somebody, a bed partner, a wife, a husband, someone brings it to their attention, or as someone has heard about sleep apnea and says, I think you've got this thing, sleep apnea. You should see somebody, and because it's dangerous. And that's usually what happens. Somebody brings them in, or they finally gotten to the point where they have to admit that their quality of life has become so compromised by their sleep apnea, their fatigue, their sleepiness, their inability to concentrate, that they finally say, okay, let me get this thing checked out.
Okay, makes sense. And then how long, once someone has a CPAP, do they experience relief and start to feel better, and their sugar levels come down, their other markers improve? Yeah,
most of the markers of inflammation improve within the first 4 to 6 weeks. So you'll see an improvement in diabetes. You'll see an improvement in blood pressure. Usually in the first 4 to 6 weeks, the markers of inflammation that we find in the bloodstream of people with untreated sleep apnea begin to resolve. Now, as far as sleepiness, a lot of people notice an improvement within the first week or two, to the point where truck drivers who have sleep apnea usually can get back on the road after 1 week or so of treatment.
Oh wow, that's great.
Yeah, so it's pretty quick.
If someone is not aware of their sleep apnea, you said 80% are undiagnosed.
That's right.
How long when they have it will they start to see more and more serious symptoms, and how long does it take until someone's in bad trouble?
Yeah, that depends upon the person. What we try to do is get them in before they develop the symptoms, but I have a lot of patients who've already had a heart attack, a stroke, or have poorly controlled diabetes or poorly controlled high blood pressure, who've had it for years. And if they had come in sooner and we treated them sooner, a lot of that could have been avoided, especially the cardiac problems, the strokes, the pulmonary hypertension. So everybody's different, and it also depends upon how severe it is. So if you stop breathing 50, 60 times an hour, there's a likelihood you're probably going to start to present with symptoms of heart problems, atrial fibrillation, et cetera, a lot sooner than somebody who stops breathing 8 or 9 times an hour. So part of it is the severity, so there's no way to tell exactly how long it takes to develop the symptoms, but we do know that a majority of people do develop symptoms and signs if untreated.
Is there any low base level that pretty much everyone has? Does everyone maybe stop breathing once or twice an hour?
They do, and that's not a problem. We feel less than 5 times an hour is considered normal. Some insurances will only, even if you stop breathing 10 or 11 times an hour, they may not cover treatment unless you have a comorbid condition that's being caused by the sleep apnea, such as high blood pressure, diabetes, heart disease, cardiac arrhythmias. So, but in most cases, we believe less than five or less is considered to be normal for most people. And it also depends on what happens to your oxygen levels during these drops. If your oxygen level just drops a little bit, no big deal. If your oxygen level plummets, even with 5 or 6 apneas an hour, if your oxygen levels are getting down into the 70s, then we take that much more seriously than we do the same number in the absence of significant drops in oxygen.
Gotcha. Okay. And then, this last question or so, what strategies can people use, even though the CPAPs are much better than they used to be, you're telling me, which is great, humidified and all that. What strategies do you encourage patients to use to get them used to it as fast as possible and for them to sleep really well?
Okay. First of all, best thing is to work with a board-certified sleep specialist. Okay, that's really important. Or a mid-level who trained in who works in a sleep lab, because these are the people who can really get you acclimated and get the pressure set properly. They understand the machines and so on. We have sessions with children who have to go on CPAP. We always bring them in for a desensitization session with some of my technicians here, and we work with them. And we do that with our patients too. If a patient's struggling, we always tell them, don't wait, don't come in after 3 months. As soon as you start if you're having trouble with the machine or the pressure or the mask, give us a call. Come right in. We're going to start working on it. And most of the time, we can resolve the issue. It may be a different mask. It might be changing the pressure a little bit, increasing the ramp time, increasing the humidification. It's amazing how often when they do come in, we can solve the problem rather quickly. But what happens to a lot of people is they get a sleep study, they never see a sleep specialist. They're sent to a laboratory by their primary care person. They leave it. They're sent a machine, the CPAP. No one works with them. And after about 2 weeks, they go, heck with this. I can't tolerate this. And there's nobody for them to see or talk to about it. And I see that all the time. That's I must see at least 5 people a week who come to us because they had given up on it for just that very reason. No one ever worked with them.
And the person that works with them is a sleep therapist, or is it the?
In my laboratory, it could be me, or I have a nurse practitioner and I have a physician assistant who've been trained by me. They're great. We have board-certified sleep technicians who work here, and they'll work with them. So we have in a sleep center. We're called sleep centers because that's what we do. We deal with all of these aspects of problems with CPAP, and we have a myriad people who've been trained to deal with it.
Well, all right. So that's one last thing I wanted to ask you is what makes people give up on the CPAP most of all? Like, what are the most common things that you have to help people overcome?
Yeah, I think there's a couple of things. Some people give up on it because they get an infection and they're convinced it was due to the CPAP, which is where, again, SoClean comes in handy to prevent that.
Right.
The other one is that people don't see an immediate improvement. They said, well, I thought I was going to be, not everybody improves rapidly. So that's another one. And number 3 is some people just can't tolerate the pressure. They find it's too high. They don't know how to adjust it. They don't realize you can go to somebody like us and we will be able to work with you and make it more comfortable. And in some cases, we have to stop the therapy and look at alternative forms of therapy. But the most common issues I find is that people either infections or the pressure is not comfortable for them, and when they come to us for those complaints, in the majority of cases, we're able to rectify it.
Is there what happens if you don't have enough pressure? Will you just continue to have the apnea, or will you then snore instead?
If the pressure is not sufficient, you'll have apneas through the night, and the way we detect that is the machines have computer chips called a smart card, and so when you come to a sleep center with sleep specialists, one of the first things we do is we download the smart card, and we can determine whether or not you're having a significant amount of breakthrough apneas. And if you are, we may need to bring you into the laboratory and readjust the pressure you need. or in some cases we can do that without even bringing you into the lab. But yes, if the pressure is insufficient, you'll continue to have obstructive apneas. Everybody has their own pressure that they need in order to keep their airway open. You can't borrow your friend's Cpap, put it on, and expect that his pressure is going to work for you, because it may not.
Yeah, well, that's what I was asking. If the pressure is 80% of what you need, would it just turn into snoring? But you're just saying it's like either yes or no.
Yeah, well, if it's 80% of need, you're probably going to end up with your airway collapsing. It's going to collapse, and we see it we pick it up very quickly on the computer chip that you're having a lot of apneas, and then we know something is wrong.
Is there any way to pulse the air if someone's like sleeping during the night and for some reason all of a sudden the pressure is not sufficient? Can you pulse the air and go to a higher pressure for one breath to wake them up, or to open up the airway? I mean, any strategies?
That's where auto titratable CPAPs come in. With auto titratable CPAPs, we set it at a pressure lower than you required in the laboratory and a pressure higher than you required in the laboratory. And during the night, the machine monitors your throat, and if it senses decrease in flow from in your throat, it increases the pressure automatically. If it senses your throat's wide open for a period of time, it starts to drop the pressure. And so the machines are auto-titratable, and that's exactly what they do. They increase or decrease pressure depending upon the status of your upper airway at a moment-to-moment basis.
Okay. And then one thing that occurred to me is, I tend to breathe through my mouth. Does the CPAP only work if you breathe through your nose or your mouth or both? That is the person choose?
Nope, doesn't matter, because we have masks that go over the nose, we have masks that go over the nose and mouth, we have masks that go in the mouth only, so it doesn't matter. If you breathe through your nose or you breathe through your mouth, that's one of the reasons to come into a laboratory, so the technicians can pick that up on the night of the test, and they'll put the appropriate mask on you, and then that's the mask that'll work for you. So if you're a mouth breather, usually you'll need a mask that goes nose and mouth. If you're just a nose breather, you could probably get away with a little nasal mask.
That used to be an insult, right? They'd call you a mouth breather, right?
Right. That's one of the major causes of sleep apnea. Is many people are mouth breathers.
Okay. I got it. All right. Well, some resources then for listeners. So I know you can't treat the whole world, even though it sounds like you'd do a good job doing it. So let's give resources of how they can see you and what areas you serve, and then the So Clean, and then if they can't see you, what should they look for?
Okay, well, I mean, we're, my place is up in northern Arizona. We're in Prescott Valley. We're the Sleep Disorder Center of Prescott Valley. And certainly if you're in the northern Arizona area and you want to be seen, we'll be happy to see you. Resources include the American Academy of Sleep Medicine. You go online and you can find sleep specialists and sleep laboratories in your area throughout the country. So that's an excellent resource. Online, So Clean itself has a very nice resource in terms of discussing sleep apnea. They've got a lot of question and answers and essays on sleep apnea. I have a website, answersforsleep.com, that's seen by a lot of people. And you can go on my website, answersforsleep.com, and you'll see discussions of numerous topics that have to do with sleep apnea and with sleep in general. And I've written 2 books, Sleep Soundly Every Night, Feel Fantastic Every Day. It was my first book, and the second one was The Doctor's Sleep Solutions to Stress and Anxiety. That was my second book. They're both available on Amazon, and they answer a lot of questions about sleep and sleep-related issues.
All right, that's great. Well, Dr. Rosenberg, it's been a really, really interesting call, and I appreciate you coming.
My pleasure. Have a great day.
You have been listening to Almost Here, Around the Corner Future Technology podcast with Richard Jacobs. Subscribe to this podcast, post a review to discover more future technologies that are poised to transform our lives for better or worse, such as Bitcoin, artificial intelligence, 3D printing, blockchain, virtual reality, and more.